come on up, ladies. Maggie's coming up too.
Unnecessary risks.
That's good to know about you. Well, I'll file that one. Oh, that mic's on. Yeah.
GTK. Do you like our front page?
That's awesome.
And we remember to acknowledge the thunder.
Sweet. I taught you well. Or actually, you came trained, which I love too. I'll introduce you guys.
We originally submitted for 15 minutes, so we're okay to
Absolutely. Oh no. Good afternoon, folks. That didn't work. Do I have to use my soccer dad voice? Okay. Good afternoon, everybody. I'd like to welcome you to our afternoon session here. This project that's going to be presenting is near and dear to my heart because I've only been with CAAN for 9 months. And one of the first things I did was help get this project back on track. And then the second thing I helped do was we got more funding for this project to run for another year. So I'm excited to introduce this. Also, this project, not only is it our great CAAN contractor, Sally, but also it is in partnership with the Dr. Peter Center, who I love very much. They have been a truly great partner for us. So much so that I think we're going to save the world together, and it's all good. So anyways, without further ado, I'll introduce Sally Woodside, and she can introduce her team, and write down all the details, ask them lots of questions. They're ready for it. They're even open to more partnerships and talking to people about doing more work. So it's all good. Enjoy your afternoon.
Miigwech Tim. Maybe that was too close. Thank you so much. Thank you for having us. I'd like to start with a land acknowledgement, if I may. So we are acknowledging we are located on Treaty 1 territory, the ancestral and original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the heart and homeland of the Métis Nation. We respect the treaties that were made on these territories. We also acknowledge the harms and mistakes of not only the past, but the ongoing injustice. And we are dedicating ourselves and moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. I'd also like to note that our water today is being brought in from Shoal Lake 41st Nation. Thank you. A bit about myself, Sally Woodside. I grew up on the Salish coastal area of Maple Ridge in British Columbia. Since then, I've spent the last 10 to 15 years in Haudenosaunee territory in Gananoque, Ontario. Currently living in Thunder Bay, home of Fort William First Nation in the Robinson Superior Treaty Territory. I am from Irish descent and very proud to be here. I'd also like to introduce Maggie, our beautiful elder who guided our 4 engagement sessions and really helped us lead those in a good way.
Thank you very much, Dus. I appreciate the girls asking me to come up here, but when they already said that we're going to be answering questions, crap, I'll have to go through the book again. I am from Passamaquoddy tribe in Maine, and I now reside in where my husband comes from in St. Mary's. We call Ekpahug, because that was their first name, was Ekpahug, and then St. Mary's because it was Saint this and Saint that. I don't know how it got there, but it got there anyway. But I call it Ekpahug. Yeah, and I am I am a Mi'kmaq too, because my dad is from Eskasoni in Cape Breton, and I am also Wolastoq. What they used to call us Malizid. That's what Mi'kmaq called us, because we were slow speakers. And but we are called Wolastoq because we lived alongside the Wolastoq River, which they took from us, and they called it St. John River. And one afternoon, the voice came to me when I was braiding sweetgrass at my kitchen table, and the voice said, "Bodaman Wizun, I want my name back." And I was just goosebumps all over me. And then this guy walks in, he said, "Mug, what do you think about taking our river's name back?" I said, "Right now, right now as we speak, you go over there and go get meetings with the city, and I want them to sign the papers." Yeah, he went over months later, a year later, we never got no paper signed. We did the ceremony. Our community did our ceremony. Our Grand Chief did our ceremony. And I sang the canoes, the homemade canoes that were made by our community members. They went from one side of the river to the other, and I sang them in. That was really beautiful. And that's the reserve I come from, because that's where my great-grandmother comes from and my great-grandfather. And I dreamt about them before I didn't even know them, but I dreamt about them. But I was so happy with the girls when we got on the virtual. I was so excited being on virtual because we cannot get together. Everybody had to wear a mask. And we cannot see one another. We cannot visit one another. So when that doggone machine box came around, my God Almighty, I was so excited. I am excited when even this mic, that's my buddy. Mike is my buddy. That virtual thing is my buddy. Anything virtual. There was one lady told us to accept everything. What's when it's made like this, what do you call these things? Machines and technology. Yeah, technology. Accept it because it is so beautiful. We use it and don't abuse it, because when we have all of that stuff, that's what brings us all together. And that's what brought us together with these papers. And I said, when I first started working for CAAN, I said, I will come, but I don't want you to put paper in front of my doggone face, because I said the very first word, if I read it, and I said, when I put it down, I can't tell you what I just read. I can't tell you about it because it don't stick in here. But anything that you tell me, or when I get together with my people, I remember it, because we are virtual people. We are people that are virtual. We got to see one another. We got to feel one another. That's what it's all about. And I loved it when we became virtual. There were so many people that was there on camera. I thank you very much. I better quit because I'll be talking all day.
Miigwech, Maggie. We'd also like to acknowledge our funder, Canadian Women's Foundation. This project, of course, wouldn't have been possible without them. And also personally acknowledging the amazing partnership with the Dr. Peter Center and the instrumental contribution of both Savannah and Carly. It's my pleasure now to introduce Savannah Swan and Carly Wellham of the Dr. Peter Center.
Thank you. Thanks, Sally. Hi, everyone. My name is Savannah Swan. I work at the Dr. Peter Center, as Sally mentioned. I'm a grateful settler and aspiring ally on these lands. For my heritage on my mother's side, it's a mix of Scandinavian, English, and Irish. And then on my father's side, my heritage is Middle Eastern and North African. So my father is a refugee from Iran. And yeah, as I mentioned, I work at the Dr. Peter Center now. Oh, I should say where I grew up. So I grew up on the Shoshone-Bannock territory in what is now called southwestern Montana, and now live on Coast Salish territory, which is where the Dr. Peter Center is located. And I'll just tell you a bit about the Dr. Peter Center if you aren't already familiar. We are an integrated care center for people living with HIV and other socio-structural vulnerabilities, such as mental health challenges, poverty, trauma, unstable housing. We have 3 main programs. One is a day health program, which provides nursing and counseling and recreation therapy, art therapy, music therapy, and daily meals. We also have a 24-hour licensed nursing care residence and an enhanced supported housing program. And our knowledge translation department, where I work, supports capacity building for supervised consumption and overdose prevention sites across the country. And we also are involved in a lot of collaborative community-based projects, such as the Wellbeing Project, which we'll speak to today. And I'll pass it over to Carly to introduce herself.
Thanks, Savannah. And thank you all for being here today and for having me. My name's Carly Wellham, and I'm a settler who was raised on Treaty 1 territory north of Winnipeg on the shores of Lake Winnipeg, where my Icelandic ancestors were uninvited guests and active participants in colonialism for the past 5 generations. So before this land was even part of so-called Canada. Today, my home is on Coast Salish territory, so the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations. I first got involved in this project. I was hired by CAAN to help out with program design and proposal development, and I'm currently working as an external evaluator for the project. Before we get going, would it be possible to get the slides up on the screen? There you go. Thanks. Oh, that was so fast. Thank you. And I'll also mention that we're talking about gender-based violence today, which is a heavy topic and a lot of triggers associated with it. So just want to emphasize that there's lots of supports available at the conference and elders to talk to if you need any support during or after the presentation. And also, please feel free to leave at any time to get up and get some tea or coffee. No reason to stay if it's not feeling great. So with that, I'm going to kick us off by talking about the issue that this project was created to address. So we know that even before the COVID-19 pandemic, there was a really urgent need to improve access to culturally relevant gender-based violence prevention and intervention resources for Indigenous women. We know a lot about this issue from some previous work that the community's done. So we learned a lot about this from CAAN's Our Search for Safe Spaces research, which was done in 2010. As well as the recent report on the inquiry into missing and murdered Indigenous women and girls, and also the CHIWO study. So all of the background information I'm going to share in the next few minutes comes from those 3 studies. If you want the full references, we're happy to share our report on it. But what those studies have highlighted is that ongoing colonialism leads to increased exposure to violence and racism for Indigenous women and girls. And that what I'd just like to echo what Laverne said this morning, that we know that it's the healthcare and social services that don't know how to properly work with Indigenous people, and that often those services themselves are sites of violence. So just to name that, that a lot of the issues that we're talking about today are present in the services themselves. We also know that when people go to these services, there are often experiences of stigma, discrimination, and racism. And something that the Our Search for Safe Spaces report talks about a lot is people experiencing triple jeopardy. So feeling stigmatized or discriminated against because of 3 things: their HIV status, their gender or sexual identity, as well as their Indigenous identity. and that together, any of those three, but especially all three, can prevent access to the support services that are trying to reach people. Unfortunately, all of those factors are really woven with stigma at different levels. And this, of course, creates barriers that prevents people from connecting with the services and leads to isolation before we even add a pandemic and all the challenges of that on top of it. We heard from the studies about how Indigenous women often feel isolated from services, either because they don't feel friendly to women or they don't feel friendly to Indigenous people. And we also heard from a lot of people that even in organizations that were more culturally safe or relevant, a lot of people were also not feeling safe going there because they were worried about being labeled as a bad community member, or especially a bad mother in the context of a colonial child and family protective services system. Or just feeling like the blame was being put on them and risky behaviors, that kind of thing. I also want to mention that the context of HIV non-disclosure has connections to gender-based violence in multiple ways. So the risk of violence after disclosing, or of stigma if your community knows your status. And then also the risk of not disclosing and criminalization and the violence of the criminal legal system itself. So all of that was information from before the pandemic. So even before then, we knew that there was a really urgent need to be doing better in the services that were being provided. There hasn't been too much information coming out over the pandemic yet that we were aware of when the program started. But there was one set of guidelines released. It was funded by CAAR, and they were called the COVID-19 Pandemic Guidelines for Support of Racialized Women at Risk of Gender-Based Violence. So those guidelines covered racialized women from all cultures and heritages, but they did also specifically talk about how for Indigenous women, it was institutional mistreatment, racism, and discrimination, as well as a lack of Indigenous operated services that were barriers for people seeking gender-based violence services, and that this led to disparities in care and disparities in access. So, of course, we know that when COVID started, a whole new slew of problems and challenges were introduced in this work. It seemed really logical that COVID would be further restricting access to services, either because people didn't want to go, the risk of going to services during a pandemic, or services weren't as available, places were shutting down, or not able to have as many people. So we set out to learn from the community about what they were experiencing, what changes as a result of COVID were coming up, and we're going to be sharing those with you today. As well, we know that there was more urgency to make sure that people were meaningfully engaged in these prevention and intervention services. And today we're going to share with you some of the ideas that came from community about how we could be changing services to do better in the context of COVID-19 and just in general. So we set out to look at how we can adapt gender-based violence programming available to Indigenous women, and especially Indigenous women living with HIV or Hep C, in response to the pandemic. And we felt that as all of this uncertainty with COVID was being introduced, it was really important to support the frontline community organizations that were doing the work to address this. So a lot of our recommendations and things we talked about were about things that community organizations could do, not just individuals. And our hope was that this would allow us to really quickly mobilize and support them to create better resources for gender-based violence prevention and intervention during COVID. So with that, I'm going to hand it back over to Savannah to tell you about the project.
Thank you, Carly. So yes, the CAAN and the Dr. Peter Center, we partnered to create the Wellbeing Project to learn about how COVID-19 is impacting Indigenous people's experience of gender-based violence, and to identify the supports, as Carly mentioned, that can be created or adapted in response to the pandemic and to this issue. Our cohort was Indigenous women living with HIV or hepatitis C, and we used an inclusive definition of women. So that included two-spirit people as well as trans women, gender non-conforming people as well. And we first compiled CAAN's existing program and research findings into a discussion document, and that served as a knowledge base for our project. We then held national dialogue sessions in each of the 4 directions for Indigenous women living with HIV to share their perspectives and to provide a space to consider culturally safe prevention and intervention strategies for gender-based violence in community. And I would again like to thank Elder Maggie. She was there to open and close all of our dialogue sessions in a good way with ceremony. She facilitated our discussions and asked questions and shared her wisdom with us all the way throughout. And Elder Betty McKenna as well was there to ground us and was there to provide support for people who may have experienced heavy emotions during or after the dialogue session. So she was there to step away into another Zoom room or on a phone call for anybody who might need that support. And it should be noted that during our dialogue sessions, we didn't specifically ask about experiences of gender-based violence. We were asking about what service providers and other community members could do to support gender-based violence prevention and culturally safe responses during the pandemic and beyond. And in the spirit of reciprocity, we held a national summit for everyone who participated in our dialogue sessions to ensure that we were meaningfully and accurately representing the perspectives and recommendations that were shared with us. So we shared the findings from all 4 dialogue sessions, and as well as some potential resources that could be created in phase 2, which we'll speak to a little bit later. This also provided a final opportunity for discussion and for folks to share any final thoughts, and also gave us an opportunity to do some project evaluation, which Carly will speak to later. And now I'll speak to what we heard from folks. So isolation was named as a key cause of the increase in gender-based violence during COVID. This was due to stay-at-home orders. People lost the ability to work outside the home, to meet up with friends who could provide support, or to leave immediately when there were volatile situations that arose in the home. So one participant said, "The pandemic has limited people's ability to have a reason to leave where they are. There's no excuse because everything's closed and you're not supposed to leave home. If you do have somewhere you can go, that's made it so much harder. For safe spaces, with everyone closing, there's limited options for where people can go. That's been a big part of it." And after referring to working from home, one participant said, "Before COVID, you were allowed those 8 hours away from him. Now stuck in a house with him, what can I do?" Others noted the challenge of having methods of communication and socializing move to the virtual space, given that a phone call or a video call could be overheard by an abuser. Some folks mentioned that virtual communicating made body language and nonverbal cues less clear, and that made it harder for others to recognize abusive situations through a screen. Also, the online nature of communication would make it easier for an abuser to track someone's interactions online. And unfortunately, multiple participants shared that they stopped accessing regular counseling services over the pandemic because they weren't afforded the privacy to have virtual appointments with a counselor without an abuser overhearing. We also heard that the pandemic has affected the personal coping skills and emotional health of many people experiencing gender-based violence. And participants shared that before the pandemic, leaving the house, which is often the site of gender-based violence and abuse, being able to leave the home helped them to resist normalizing the violence and reminded them that people were thinking of them. So one participant shared, "When you left the house and had other life experiences for 24 hours, you were able to contrast your unhealthy, dangerous situation and the threats to you with other experiences. Now it's 24/7 feeling the abuse." And another followed up with, "I also think that with COVID, say your life revolves around this negative abuse and everything, that becomes your comfort zone. Because of COVID, it makes it okay. For the abuser, it might even make it seem okay." And after we discussed how social isolation was a key risk factor for the increase in gender-based violence over the pandemic, we also got into discussions about how disclosing, when folks disclose their HIV status, they were also faced with that social isolation and marginalization. And they noted that the stigma and marginalization has increased over COVID because education about HIV treatment and prevention was disrupted by social distancing measures. So one participant shared that I would love to go into community and table events and education sessions and spread the word about U equals U, but because of COVID, I'm not afforded that opportunity anymore. So someone said COVID supersedes everything, and while HIV is still a pandemic, it is not acknowledged. And this is, really just reiterating what Elder Albert has been saying this whole week as well. And they also connected the increase in gender-based violence with increased racism over the pandemic. So one participant said, there has been even more racism too in the past couple of years, just so much ugliness. I think as we go through the pandemic and just how more violent some communities in our country have gotten, it's unnerving at times. And finally, we discussed how many community services were closed or were operating at limited capacity, making it difficult for people experiencing gender-based violence to access supports. And some participants shared that in particular, space within shelters was limited because of the social distancing requirements. And with the skyrocketing costs of rent, that was making it very difficult for single mothers escaping violence to find emergency housing for themselves and their children. And now I'll pass it over to Sally, who will talk about the recommendations that were shared with us.
Thank you, Savannah. So yes, out of these engagement sessions, as she lets us know what we heard, and from what we heard, we now have recommendations formally made from the participants. So one of these recommendations, or the first one, is having staff with lived experience. Participants were in agreement that for gender-based violence prevention and intervention, it was most helpful to have service providers with similar experiences, whether that was an Indigenous woman who was also living with HIV, or an Indigenous woman who had also experienced gender-based violence. Participants described finding great power and comfort in knowing that someone else had gone through something similar. One participant described the empowering nature of these exchanges with service providers who have also experienced gender-based violence. I quote, "We understand one another because we went through that and have that they can speak to about it, because that's how we can help ourselves. It makes people feel better when they hear it from their own people. Then they will start talking about it amongst themselves." People also found that Indigenous people were more likely to provide support in a way that felt uplifting rather than disempowering. One participant shared, "The people running the centers and pathway houses and emergency shelters, they use the word help a lot. That puts people on a different level. The elders never used to use the word help. They'd say, go be with them. When you go be with somebody, you are not above that person. We see people placing themselves above our own people because we have this attitude that I am helping." Another participant agreed that the opposite of help is that somebody is helpless. And if somebody is offering their help, it means that I am helpless, and that really affects my self-esteem, end quote. Participants agreed or appreciated that the number of people with living and lived experiences working in health and social services was increasing, and that it helped them to know that their needs could be considered and that their care was less likely to be stigmatized. People with lived and living experience were recognized as more likely to understand how difficult it can be to access services. To praise these people for taking the step to access services, as well as having the need to be adaptable and support the people experiencing gender-based violence. One participant shared, "When we talk about professionals, they have learned out of the book, and it's got to be out of the book or no other way. We need adaptability, as our people have always been able to adapt, and that's why we're still here." Participants shared examples of how hiring Indigenous liaisons or mediators to build bridges between service providers who are non-Indigenous or not from the local community could help ensure that people feel welcome while accessing services. On a related note, it was recognized that participants need to be compensated for their expertise. Participants agreed across the board that even if they did not have professional designations or official positions, people with similar lived experiences had very helpful expertise and they should be compensated. They need to have their time and expertise recognized and paid for. I'm so tired of people who think that they can say great job and walk away and leave our people standing there. That is not right. And another noted, if I am being paid to do education around HIV, or I am calling in someone with experience, we need to pay them too. We rely on their expertise and it should be paid for accordingly. So our second recommendation that arose in our dialogues was to develop a standardized template that service providers could use to collaborate with people experiencing gender-based violence and design a personalized safety plan. Participants said it would be helpful to have a flexible template for safety planning so that they could have actionable plan for responding to a crisis. This recommendation was explained by one participant as, from my own personal experience in years past, I remember being asked if I had a safety plan, and I would say, oh yeah, I have friends or a family, but it wasn't talked about enough where it could be utilized if it was happening in that moment. By asking questions like, where would you go if you were to flee right now? What would you do if you couldn't phone someone? Is there a safety word that you could tell somebody over the phone or a physical hand gesture? I think this is something that we can do for women right now. It was emphasized that safety plans should include people who one can call at any time of day. It was emphasized that it's particularly important to have someone to call during the night, particularly for women who would like to avoid calling the RCMP, where many expected to have more stigmatized experiences. Participants also shared their ideas for safety signals that people could utilize when they need to communicate that they are experiencing gender-based violence and need support. For example, one participant shared that when she could feel the tension building and she knew an explosion of violence was imminent, she would use the code word, I'm going to make some chocolate chip cookies, and with her children, so they would be able to, or they would know to prepare to leave quickly without arousing suspicion from their abuser. Participants also discussed how the community can be a part of the larger plan to the response to gender-based violence. They questioned how community members could be educated and how they become allies to gender-based violence response and start creating community plans as a whole that would enable people to respond in urgent situations rather than ignoring them. Participants appreciated seeing posts on social media, which would suggest hand signals that could be used on video calls to communicate to someone that they are experiencing gender-based violence. This actually inspired an idea to have a physical object or a sign that we could maybe design or create to have placed on your fence, and this would signal that this home was a safer place for people experiencing gender-based violence, like the Block Watch. They thought that this could be people experiencing gender-based violence as well as their abusers, that there is support and safe places to go out across their community. So one participant shared, and I quote, "It's not even in words, but knowing if I had to run to a neighbor, who will open the door for me at whatever hour of day or night. We know neighborhoods have changed over the years and that people are living their lives and it's COVID, but can people still signal that you're an ally by having a positive sign or something indicating that you're a safe home?" So our third recommendation was creating and having culturally safe and responsive services. So participants highlighted the importance of cultural safety in accessing services. When asked, what is it that demonstrates the services are culturally responsive, one participant said, "Am I allowed to smudge there? Is there an elder available that I can speak to?" And another said, "Culturally safe and accessible services looks like an organization that women, Two-Spirit, trans people, and youth can access. It seems that Indigenous friendship centers are always the place where I can go." One participant shared that involvement of culture and ceremony is why CAAN's programming has worked well for them. Some other participants also spoke to the need to ensure that cultural activities are available to all, including people with HIV. They shared that it can be difficult to find some ceremonies, such as sweats, which will be inclusive of people living with HIV, and found this to be a form of violence as well. So another recommendation is just the premise of building community. We discussed how communities can be the antidote to social isolation. It was recognized that women do the majority of domestic and childcare labor and experience inequitable pay, which can make building and supporting community even more challenging. Women discuss ideas for building community, such as creating a community kitchen where women could cook and eat together and share stories around the table. Another idea was creating a weekly group on topics such as self-esteem, which could give women reason to leave their house and improve their skills while it not being explicitly about gender-based violence. Participants shared about the communities they'd formed with other women in similar groups they had participated in. Community members were also recognized as having a role in addressing stigma, discrimination, and other forms of violence that service providers can perpetuate against Indigenous women experiencing gender-based violence. Participants spoke of how difficult it can be to continue standing up for yourself when you constantly are experiencing mistreatment and anti-Indigenous racism when trying to access services. This was particularly true for people experiencing gender-based violence who may not be feeling connected to their voice or their self-esteem. Many participants have called for other members of the community to intervene when you see something, say something, and how meaningful it is when someone interrupts a negative experience. In one participant's words, it's important for women to have community because they are great at helping each other. And when I witness of women helping women, that's when you are going to start to take care of yourself, and that's when you are in your community. I think when you have experienced gender-based violence and marginalization, something your own family sometimes perpetuates, it is having that sense of community, and even online community, that can provide this nurturing support. It is what's needed for your body and soul. So another recommendation out of the engagement sessions was creating allyship that would reduce stigma from service providers. So intersecting stigma against indigeneity, HIV, gender-based violence were recognized as key barriers to gender-based violence prevention and intervention. Service providers were recognized as perpetrators of violence as well, such as verbal violence and racism. Participants shared stories of encountering stigma against HIV in service settings, which had discouraged them from accessing needed gender-based violence services, even when it wasn't related to their HIV status. Whether accessing services, police work, child and family services, or gender-based services, the stigma that women experience was a key barrier. Trust in many of these services has been lost due to reoccurring and stigmatizing experiences. Education on the topic was emphasized as a recommendation for service providers, including more training on sexual violence response, HIV, and cultural safety. Participants also stressed the need to visit the people in the community to better understand what they need or what they want. One shared, "You can't work out of the office and say you know what the people are going through." Having service providers of all genders was also recommended, particularly for issues of gender-based violence. Participants also emphasized the importance of educating healthcare service providers about cultural safety, HIV, and gender-based violence early on in their training. One participant shared, "Indigenizing healthcare means we need to have it happening more at a grassroots level. The people that train the institution and hospitals, that change is a long time coming. There are allies out there, but the challenges are significant, and it breaks my heart that urgent and hospital care is not always hospitable to a lot of our people." And another recommendation is the intersection between gender-based violence and HIV disclosure. So participants drew a clear connection between their HIV status and the emotional and physical violence they experience in intimate partner relationships, making disclosure of HIV status an important concern related to gender-based violence. In the context of COVID-19, virtual appointments raised concerns about disclosure, as sharing sensitive and personal information over the phone without an understanding of who is on the other end did not feel safe. So touching base on more about privacy, it also impacted the access to services. Participants shared that works with service providers and community centers in a small city, for instance, or a First Nation, that many Indigenous people from nearby reserves would access the HIV and hepatitis C virus-related services at centers rather than on reserve in order to avoid stigma and protect their privacy. However, if you did leave your reserve to access services elsewhere, they were more likely to experience anti-Indigenous stigma and discrimination in these non-Indigenous settings. Many participants shared stories of how the stigma they experienced in healthcare discouraged them from accessing much-needed HIV-related care or otherwise. They identified stigmatizing experiences in healthcare as key moments when people fall through the cracks. And there's many negative health outcomes and dangerous consequences as this relates. Participants were frustrated that they needed to disclose their HIV status or their experiences of gender-based violence frequently and sometimes publicly at medical appointments. Participants shared, "It's embarrassing to stand in line with all these people behind you, say at a reception desk, and nobody needs to know that you are going in there for, what your appointment is for. That person behind the desk should know." Furthermore, consistency in service providers was preferred in order to minimize the number of times people had to disclose their status of gender-based violence or their HIV status. People expressed frustration over having to constantly explain their situation to different service providers at the same setting, as it meant needing to disclose sensitive information, example, your HIV status, which can be, of course, re-traumatizing. So we had a few other recommendations that arose out of this, and that was creating a HIV status card. For example, there was an idea that we would have a name saying that you are HIV positive that you can hand over to a reception or at your medical appointment, and then that person isn't having to ask over and over once you hit the doctor and then the pharmacist, so you could just pass the card. Participants had ideas on these cards, if we were to create them, that they would have powerful statements such as, I am not what runs through my veins, I am what runs through my soul. Or, HIV doesn't have me, I have HIV. And lastly, participants shared other strategies that they could use to reduce the likelihood of experiencing stigma from their service providers, such as asking their HIV specialists for referrals to other service providers. They recommend using your HIV specialist. They could then recommend inclusive, non-stigmatizing treatments and care of people that they would recommend for you to use. Okay, we got one more. Harnessing key moments for intervention. So service providers need to be equipped to assist women who access support for gender-based violence. It is important for the service providers responding to appropriately and swiftly when someone experiences gender-based violence was strongly emphasized. Participants reflected to the energy that it takes people experiencing gender-based violence to come forward and to disclose their experiences, and shared that the service providers need to recognize this key and pivotal moment. As one participant shared, "In my experience and observation, there is one chance that a woman is going to reach out for help. And if she doesn't get that help, and if you are in a systematic flow of abuse and you use your voice and your call for help isn't answered, she probably won't reach out again." Another agreed, in quotes, "If a provider fails, the person experiencing violence may never ask for help again. It's literally a life or death opportunity." They emphasized that women must overcome huge amounts of fear and codependence and risk their abuser finding out in order to reach out for help. Participants shared many stories, the dismissive treatment from service providers, RCMP, 911 operators, and that they or their friends received when reaching out for help. They suggested that service providers be adaptable and recognize that going above and beyond their regular duties or their 9-to-5 schedule is necessary in harnessing this key moment of change. Participants also recognize that it is challenging, particularly in small communities where women will be known to service providers. They may not believe them or may have to access the same services many times. One participant shared, "There's a sense of, oh, it's her again. Am I going to bother trying to get her help when she's just going to stay with him anyway?" So they take longer to get these people and get them into a safe spot. They need to help her regardless of how often she gets into that cycle, because it's all she knows. Even if she's constantly going back, She constantly needs this help and support to escape from the abusive relationship. She needs help to heal.
Okay, so yeah, obviously a lot of learnings and perspectives shared with us. Looking forward, as mentioned, we were funded for the next phase of this project. And so from all of the honesty and wisdom shared with us over the dialogues, we are now situated to create resources and trainings that will increase service providers' capacity to provide stigma-free, trauma-informed, and culturally safe services to address gender-based violence among IPHAs and IPHCs. And we will do this through a national knowledge transfer campaign. So first, we will be creating knowledge bundles, which will include useful messaging, resources, products, and teaching tools to be used in a variety of local contexts. And this process will be led by elders and interested study participants, as well as our new co-lead for the project, who is an Indigenous person with lived experience. They're a non-binary person. They also identify as a mother. And we will be disseminating these bundles to our collective network of frontline community-based service providers, beginning with a virtual launch event where we'll be showing the knowledge products and the bundles that we created and providing some teaching on how best to use these tools actionably in community. And Sally already detailed a lot of this, so I'll just really quickly mention some of the resources that could be included in the knowledge bundle. So the safety planning template that was mentioned, which would be a template for service providers to create a really detailed safety plan in collaboration with an Indigenous woman experiencing gender-based violence that is something that actually can be utilized in the moment. And then also that what was mentioned in terms of safety signals. So this would be both for people experiencing violence, so words and phrases and hand gestures, and as Sally mentioned, also for community members and organizations. So physical indicators that this is a safe space where you can, if you're experiencing violence, you can come and access support here. Also mentioned the anti-stigma and allyship guides, and these will be created by Indigenous women living with HIV for community members, which will teach prevention and intervention strategies in the cases of gender-based violence, racism, and anti-HIV stigma, or HIV stigma. And these disclosure cards that Sally was mentioning, I don't love the term disclosure cards. We're still workshopping the title. I like positivity cards. But yeah, I want to mention that this recommendation arose from a very context-specific safety concern. And this was, specifically in a busy waiting room where one is not comfortable, mentioning their HIV status out loud, that this would be something that can be shown to a receptionist while arriving at a medical appointment. So very specific. And the participant, again, yes, someone else expanded on this idea and said that this could actually be more of an anti-stigma and education tool. So instead of focusing on I have HIV and that's something I should ever be ashamed of, it's rather, that quote of, you are not what runs through your veins, you are what runs through your soul, but know that I've had certain experiences because of this status. And I believe I'll pass it over to Carly to speak to evaluation.
Thanks. I know we're running out of time, but just wanted to share with you all what we heard on the external evaluation we did for this project. We held semi-structured group discussions at our final summit just to see if we were being successful in achieving our objectives, and also capture the lessons learned in the first year of the project to make sure that phase 2 is really as good as it can be. So we were looking for feedback on how the dialogues went, how they impacted participants positively or negatively, if people felt heard and respected, or a sense of community at the dialogues, and anything else that they might want to share to help us improve the work. The results revealed that we achieved our objective of identifying gender-based violence impacts on Indigenous women and people living with HIV and Hep C in the context of COVID-19. So some things we heard were that participants felt really good about addressing this issue with other Indigenous women. So at being at discussions facilitated by Maggie with other people with similar lived experiences, people felt good about, which I'll share more about on the next slide. But a few other smaller things were we received feedback that it was really meaningful that this work was led by community-based organizations, specifically that it originated in CAAN and then with the Dr. Peter Center as well. So a lot of people who came to the dialogues heard about it through these organizations, which they said were places where they felt safety or that they had trust in. And that to them, that really made a big difference compared to it coming from an academic institution or a medical clinic. They felt that this encouraged a community approach where they felt there was more space for people with lived experiences of HIV or of violence instead of that top-down approach. We were also really happy to hear that that led to a sense of community and that addressing the issue as a community made them feel inspired about what is a pretty intense topic. When looking at the structure of the events, we received feedback that the group size and the duration was appropriate. So we met for about an hour and a half every time, which gave us a lot of open space for discussion, as well as starting with song and prayer from Maggie. The size was an interesting one because, you know, you always want your project to be well attended, and we thought that, 10 or 15 people would be a really nice number. We had much smaller numbers. Most of the discussions had about 5 people, but that was something we actually got positive feedback on, that a lot of people said if there were more, I might not have spoken. One participant said, the small groups made it easier to open up and be honest when we're all strangers online, but we could open up about our statuses, our feelings, and even our traumatic experiences. So this illuminated that it helped to feel safer, which led to better engagement and I think more meaningful results. And those feelings of safety are really important when we're thinking about the triggering and traumatic nature of talking about violence. Participants expressed appreciation that we did have elders involved, as well as counselors on each call to help guide the discussion or talk in a different room if needed. One participant shared, which led to a really great discussion, that the opportunity to participate in this made them feel really proud of how far they've come in learning to manage their triggers, to be able to be part of those discussions, and that it encouraged them to take better care of themselves. So we had a nice discussion about how folks might want to take care of themselves after they log off that Zoom call. Next slide, please. Thanks. And just a few quotes we wanted to end with. As Sally said earlier, something that was talked about was that community is the antidote to social isolation, which is the conditions that we talked about violence thriving in. So we found that the project helped make sure that it was the voices of Indigenous women that were contributing to this response. And a lot of participants said that felt really empowering. So in the words of participants, talking to other women and knowing that I'm not alone, I'm in this with them, makes me want to be part of the change too, and I feel better. And another participant said, my experience of the dialogues was, I have a sense of feeling like I'm part of the solution, that I'm combating anything related to the stigma of HIV to domestic violence. So that to us demonstrated the power of grounding our responses to violence in the perspectives and experiences of Indigenous women with lived experience.
And that's it. We just like a special thanks to the women who joined us and shared with us so openly and honestly, as well as miigwech to Elder Maggie Paul and Betty McKenna for guiding those national engagement sessions in a good way. And again, thank you to our funder, the Canadian Women's Foundation. Questions?
Just want to ask if there are any questions for the ladies.
I'm sorry about that. weird questions in my mind. Good. Thank you for your presentation to begin with, and good hard work. I have a couple of questions, and one of them is, when you were doing your gender-based violence studies, did you look at same-sex couples as well? Because we always think in the binary system when we do research, and we don't think about other stuff. And when you talk about women, did you also have transgendered women? Because that's also an important part. And when you define gender-based violence, and then at some point you talk about sexual violence, there is a difference between both that I really want to be clear, because sexual-based violence is exactly that, rape, right? Sexual assault and things like that, as opposed to gender-based violence, where it could include being beaten up and all kinds of different things. So I just want to know how you made those distinctions as well. Thank you.
Yeah, thank you for that question. It's very important. I can speak to that if everyone's okay with that. Yeah, so yeah, our population, we were inclusive of trans women. Trans women are women. As I mentioned, two-spirit people, gender non-conforming people, non-binary people, and any sexuality that was represented as well. So you know, gay and bisexual, lesbian, everybody from the LGBTQIA plus community was represented. And yes, we did have, you know, people mentioning, you know, in one of the quotes that I read out saying, I'm stuck in the home with him, but we did have participants sharing that they experienced violence and abuse within a same gender couple as well. And yes, of course, you know, you can experience, you know, sexual violence and sexual trauma is separate and is a form of gender-based violence, but is you know, gender-based violence is more of maybe not an umbrella, but it encompasses it, right? So gender-based violence can be, you know, controlling and abusing in other ways. But yeah, when we speak about the population, the way I conceptualize it is people who are at risk of experiencing misogyny of any kind. And of course, that includes trans people and non-binary people. Yeah, I hope that answers the question.
I'll just quickly add to that. I apologize, we don't have information on how many people who participated were under the LGBTQ2S plus umbrella or in same gender relationships. We made the decision to not collect that demographic data, just feeling like we were already asking for so much sensitive information that no one needed to check those boxes to start.
If I may, one last question, and that is this whole idea of the card.
Yes.
Like, I understand what you've expressed, but in my generation of being in the trenches for HIV and hepatitis C, we fought against that kind of disclosure. So while we understand that might alleviate the stigma, I wonder how many of your participants, like the percentage of your participant, that's a good idea, and their age range, because that's also a very important distinction from the older to the younger. Thank you.
Yeah, so when we originally received that recommendation, it was from a few of our participants. And then when we had that share back, that conversation was actually very interesting because we were bringing up more ideas and opinions, and, you know, there were some disagreements with that disclosure card, you know, and then we decided, you know, there could be some issues around it. We would decided that if we were to move forward with that, there would not be names. It would just be, you know, like the powerful quote about like the HIV, I have HIV, HIV doesn't have me, or some sort of things like this that you could choose to carry if you so chose, but it wouldn't be anything with personal information. But yeah, it was a very interesting conversation after the fact, after it was a recommendation. So it's still being discussed.
Is there any other questions in the room? Jump up to my podium here and just say thank you very much, folks, for participating. Thank you very much for our panel.
Thank you.
Come here.
Miigwech.
So proud of you guys. You're my little dream team. It was great. Maggie, you have something to say?
I just want to say it was really awesome working with these girls. And I really learned a lot about HIV and AIDS, but not on paper.
Yeah.
Not on paper. I've really learned a lot. And when there's a stigma, you know that stigma? Oh my God Almighty, if we didn't have that word in the dictionary, that should be thrown out of there. You know, because there's a stigma between HIV and AIDS people, stigma between children that are, what do you call that, when they have autism, stigma who has mental illness, stigma who wants to be dressed with one shoe different color than the other, stigma for everything. You know, if we could all just love one another, if we all took off our clothes, we would know who's one who's got the biggest money or who's one who had better education or whatever. We'd all be the same. One might be plumper than the other, skinnier than the other, so what?
Can confirm.
So what? You know, people are people, no matter what color you are. I just love people, you know. And that's the beauty of it all, you know, when these women, and there's a lot of every one of you that are here doing your own presentations, you did your best. You did the best of your ability to whatever you did. You know, that's what I want to say. Awesome to all of you. Awesome to everybody. Thank you. I want to sing the song for all of you.
Thank you, because I was afraid to ask you to sing.
Major. I thought it was a dog.
And on that note, thank you, Maggie, for honoring us with that song. I have some parting gifts. And thank you, folks. That's it for today. I think, well, yeah, you're the closing act. So there's coffee and stuff coming out. Thank you.
Start.